basically you will have the ZN stain practical for 20 marks in your final examination as well as in the prelim examination. And I want all of you to do this ZN stain perfectly. I'll share the questions which we generally asked during the ZN stain, and believe me, we ask questions to all of you, the same questions. And I want all of you to follow this, okay? So today we will be discussing about the ZN stain. I have a question bank. Let's see if I could able to find it out. Anyway, we'll have the presentation only. So all of you are aware that Ziehl-Neelsen stain is one of the important staining technique as exam point of view, as well as the the practical point of view, both theory as well as the practical. And we all should know, when we are talking about the ZN stain, we are talking about the a fixed set of questions which are related to Mycobacterium tuberculosis, atypical mycobacteria, and Mycobacterium leprae. You must read 3 chapters for one ZN staining, and generally we start ZN staining with the question of what is the procedure of ZN stain. And I am sure you all are aware of the procedure of ZN stain. Why do we heat the carbon-fuchsin in the ZN stain? And the answer is that as the cell wall of Mycobacteria is very sticky and the primary stain does not penetrate easily, so we have to have some mechanism to make entry for this carbon-fuchsin primary stain into the cytoplasm or protoplasm, so that the mycobacteria which are there in the sputum sample will get stained. Okay, so all that is why we generally heat the carbon-fuchsin, we see to it that we don't boil the stain. What will happen if we boil the stain? The stain will get corrupt and your smear will get charred, and it is very difficult to find out the organisms, because the charred material from the staining technique will also show a pink color as of the bacilli. So it will be very difficult for all of us to find out the Mycobacterium tuberculosis bacilli from that smear. Okay, so that is very essential. You must know why do we heat the carbon-fuchsin. It just disrupts the cell membrane and it destroys the lipids and all that, and because of which the pore size will increase, and then the stain will go inside. And after some time, we keep it for almost 7 minutes, if you remember. Then it remains in the protoplasm, and then it doesn't come out easily even after the next step is of the decolorization with the 20% H2O support. We all know that it is a very high concentration of acid which does not decolorize easily these bacteria, like mycobacteria of course. And the other bacteria which are non-mycobacteria will get easily decolorized. As we have seen in the gram stain, only few seconds are essential with the acid alcohol to remove the stain from the protoplasm, because they do not have the intact cell membrane as of mycobacteria, which consists of mycocytes, mycolic acid, high lipid content, which makes the cell wall very sticky. And once the stain goes inside the protoplasm or cytoplasm, it won't come out easily, even if you are decolorizing with the help of high concentration of sulfuric acid, that is H2SO4, 20% H2SO4. And then finally, to want to know the rest of the bacteria, we have to stain with the counter stain, that is methylene blue, and we stain with the methylene blue for 1 minute. Of course, some amount of stain might go into the Mycobacterium protoplasm also, but it will not replace the original pink color which was taken already by the Mycobacteria as a initial stage, that is the primary stain. And those bacteria which does not have these cell wall constituents like mycocytes, mycolic acids, and high content of lipid will take this methylene blue in it, and they will appear as a blue color. So interpretation of Zn stain is the acid-fast bacilli are in pink color and non-acid-fast bacilli are the bluish color. So what is the principle of the staining? Principle is that those organisms which has got the cell wall content as mycolic acid, mycosites and high lipid content are very difficult to stain with the normal stain. So we have to heat the carbol fraction and add to the staining smear, so that the stain will penetrate and they'll get stained with the primary stain. And those who does not have these cell wall constituents will lose the stain after decolorization and they will have the counter stain. And then the next question would be on the what are the different modifications in the Zn stain. And then first modification is about the Gold-Kinyan method. That is the generally used for staining of oocyst of Isospora bailey and Cryptosporidium parvum. And then there is a modification in the concentration of sulfuric acid, that is 20% is used for Mycobacterium tuberculosis, 5% is used for Mycobacterium leprae, 1% is used for Nocardia and Actinomyces, not myces. Actinomyces is a bacteria and Actinomycetes is fungi. And then 0.5% for spores, the bucculates, all those things. Okay, this is the second modification. And third modification is, instead of the carbon friction, we can use picric acid and picric acid and malachitri. So these are the three modifications which are there in the Zell-Nelson stain. Okay, and then the examples of acid-fast bacilli, examples of non-acid-fast bacilli. You can see it here in my screen, on your screen now. You could able to see the screen, right?
Yes, sir.
Okay. You can see here, you can see here that the Mycobacterium tuberculosis is one of the acid-fast bacilli, then which causes the tuberculosis in the humans. Then you have Mycobacterium bovis, okay, which causes the tuberculosis in the bovine. And then you have Mycobacterium microti, which is causing the tuberculosis in the murine. And then Mycobacterium marinum, which is causing tuberculosis in the human. So all these Mycobacterium tuberculosis are acid fast. We generally call it as a and B. Okay, so this is the what you can say, the examples of acid fast bacilli. Then you can also write example of another acid fast bacilli, that is Mycobacterium leprae, which causes the leprosy. We all know this is the chronic granulomatous disease of extremities. Okay, so the Mycobacterium leprae also is one of the acid fast bacilli. Then we have the atypical Mycobacter, which are also, you can write it as an example of acid bacilli, photochromogens, so scotochromogens, non-photochromogens, and then rapid growers. These are the atypical Mycobacteria. Examples we have tried to remember how this photo is related to sunlight. Then I have told you to remember that Kansas City in the US, which has got the light as a Sangillatuna. If you remember, I don't know whether you remember or not. So Kansasi is the organism name. Okay, so this is about the photochromogens. Then scotochromogens, Mycobacterium scrofulacea. म्हणजे पहिलं scrofulacea असं लक्षात ठेवायला सांगितलं. I think if you remember, scrofulacea. Okay. Then non-photochromogens, generally ulcerans. We all know that we all suffer from the ulcerans. So I have told you that remember this as a name of the organism as ulcer, mala ulcers. And then rapid growth, which I have told you, your generation just chill. Okay. So Chiloni is the Mycobacterium species, which is you must remember for example of rapid growth. So these are the four typical Mycobacteria which also comes under the acid fast bacilli. Okay, then you have saprophytic, other saprophytic. These are also saprophytic, and there are certain other saprophytic Mycobacteria which can also be written as an example of acid fast bacilli. That is the Mycobacterium butricum, Mycobacterium feli, stercoris, and then smegmatis. So all these are the examples of the Mycobacterium, acid fast bacilli. Now we know the examples of non-acid fast bacilli. Non-acid fast bacilli, like all the organisms except Mycobacteria. So you write any example other than mycobacteria like Salmonella typhi, Streptococcus pyogenes, Streptococcus mighty, Streptococcus salivarius, Streptococcus sanguis, Vibrio. So all the gram-negative, gram-positive organisms you can list out under the headings of non-acid fast bacilli. Okay. Then you must also know the various aspects of mycobacterium. What do we do for a sputum sample? Do we directly inoculate onto the culture media, or we perform Z stain? We used to inoculate directly onto the culture media, or we used to prepare the smear also and stain with the Z stain. But to avoid other organisms, we have to have the decontamination process for the sputum sample. And what is the decontamination method? Decontamination is nothing but we do not want unnecessary microorganisms to be stained or to be cultured onto the Lowenstein-Jensen medium, which is one of the important culture media which we use for cultivation of mycobacteria. So what do? We just inoculate. We add the equal amount of sodium hydroxide into a sputum container which has a sputum sample. We keep it at 37 degrees Celsius for half an hour or 1 to 1 hour. Then we centrifuge that, and then supernatant is discarded. To the deposit we add phenol red, 1 drop of phenol red, and then we neutralize that phenol red with the 1 normal HCl. And then that deposit we inoculate onto the Lowenstein-Jensen medium, and we also use it for the smear preparation of the smears. The advantage of having decontamination method, as I told you, that we do not want the unwanted microorganisms from our oral cavity to contaminate the smear or the LJ medium. They might overgrow and they may interfere also. So we want to have only Mycobacterium tuberculosis bacilli in that sputum sample. So that is why we perform the decontamination method, and the decontamination method is also called as Petrov method. That is the name of the scientist which has invented this method, Petrov method. Okay. And this is for the sputum sample. And for the urine sample, you have the oxalic acid method, oxalic acid. Okay. That is for urine sample. If we want to decontaminate urine sample, we have to take the oxalic acid. Again, the same procedure is there. Take the equal amount of urine and oxalic acid, and then keep it at 37 degrees Celsius and centrifuge, deposit the phenol red and neutralize with the 1 normal HCl and inoculate onto the culture media. Actually, urine sample generally used for genitourinary tuberculosis. Okay, genitourinary tuberculosis we collect the urine sample, and for permanent tuberculosis we generally use the sputum sample to know whether the person is suffering from pulmonary tuberculosis. You also should know what are the different classes of mycobacteria, like obligate pathogens. Obligate pathogens means they are intracellular present and they are known to cause the diseases like tuberculosis, Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum. And there are certain mycobacteria which are also referred as the opportunistic pathogen. Why do we call it as the opportunistic pathogen? Because they themselves are not the obligate pathogen. An opportunity. And when do we get when these organisms will get the opportunity? If a person is HIV positive or having the immunocompromised status, that time any organism, forget about the mycobacteria, even Staphylococcus epidermidis.
So you're not audible.
Other than tuberculosis. If you see here, it is written MOTT. So if you get a short answer question on MOTT, you should write about the typical mycobacteria. Okay. So mycobacteria other than tuberculosis. And then they have given only 2 examples here. Of course, we know there are lots of examples. Mycobacterium kansasi, which is photochromogens, and Mycobacterium chiloni, which is the rapid growers. Then you have saprophytic. Saprophytic means they are present in the environment and are dependent on the chemical compounds which are there in the environment. And these are the organisms which are also important in causing the opportunistic infection again. and the important species are Sphegmatis, Telly, Stercoris, and the Butyrichum. So all, see, whenever you are attempting the Zn stain, you must read these points from your Mycobacterium tuberculosis and the atypical Mycobacter and the Mycobacterium leprae. Okay, this is the actual Zn stain, how bacilli appears. If you see here in the staining, you can see these are the acid-fast bacilli. Okay, and can you see here there is not, they don't get smoothly stained. Okay, there is a gap. You can see here there is a gap. Okay, this is also called as beaded appearance. This is also called as beaded appearance. Why? Because there are certain granules inside the Mycobacterium tuberculosis protoplasm, and that's why they do not get smoothly stained. बघा तुम्ही कुठलेही smoothly stained नहीं है. Okay, there are certain gaps, and all these are acid-fast bacilli. Okay, and you know why do we call it as acid-fast? Because they resist the high concentration of acid. They are non-motile, non-capsulated, non-sporing. We know this sentence when we are attempting the morphological characteristics. All are non-sporing except few, right? That is Clostridia and Bacillus. Other are non-sporing. Then we also talk about the size. Then a little bit about their morphology and why they are called as beaded, because they do not stain uniformly. So this is why they are beaded appearance. Okay, this is one of the beautiful slide we have for the studying the cell wall of the Mycobacter. You can see here, entire this much is the cytoplasmic membrane. Okay, and then you can see here they still have the peptidoglycan, lipoarabinoamine, and then arabinogalactan. This is what is mycolic acid, which makes them very sticky. Then there are certain mycolic acids also, mycosites also. Then lipids is also there. So entire cell wall make the organism very sticky. Okay, and this is why the stain does not penetrate easily unless and until you destroy these lipids and all that, so that you are making way to go inside the stain, inside the protoplasm. So that is why it is called as acid-fast stain, and that is why we heat the carbamazepine to enter the stain inside the protoplasm. So acid-fastness is due to the presence of an unsaponifiable wax. It is wax, and you know the property of wax, and that is because of the mycolic acid, or to a semi-permeable membrane of the cell wall. So that this makes them more sticky, and once they become sticky, it's very difficult to penetrate the primary stain inside the protoplasm. We should know what is the culture media which we use. As I told you, only Mycobacterium tuberculosis and atypical Mycobacter are able to cultivate onto the Lowenstein-Jensen medium. It is also called as LJ medium. We generally write as a LJ medium. But except the Mycobacterium leprae does not grow onto the Lowenstein-Jensen medium. It is difficult for Mycobacterium leprae to cultivate onto the LJ medium. They don't grow. They require the 9-banded armadillo. So this is also, we ask during the viva of oral viva for theory also, we ask these questions also. Of course, we may ask these questions during the practical viva also. So LJ medium, what is the type of LJ medium? It is a selective as well as the enriched medium. And why it is enriched medium? Because it consists of the egg. It is the egg containing medium. What are the different selective medium or the enriched medium which we use for cultivation of Mycobacteria? Then you can say it is a Loeffler, where serum is there, where Pavlovsky, where potato is used. Now we don't use this. We use LJ where egg is used, and then Tarshi's for where blood is used. So, and if you see what is the temperature, it is almost 37 degrees Celsius for all the bacteria except few. And then pH is almost neutral, and then this is more important. They require almost 2 months to you require 2 months to say that the Mycobacterium tuberculosis does not grow onto the LJ medium. So it is very essential. 2 to 8 weeks. Generally, in second week or third week, they start growing. Actually, you can see here growth. You can see here there is a growth. Okay, on both the slant. Okay. So for this growth, you require almost 2 to 8 weeks. But to say there is no acid-fast bacilli in the medium, you require to continue the incubation for the 8 weeks. Okay, we may ask you what are the different solid media or liquid media which we use into the for the cultivation of this. I have already told you. I am not going to repeat. Okay, we also use the liquid medium like Dubos, Middlebrook, Proskauer medium. Then what are the characteristics on the solid media? They are very dry, very rough, raised. It is very difficult to make smear because these are very dry. It is difficult to make a smooth suspension. Then you have the latest technique of Bactec, Gene Expert, MG system to identify the microbacteria. We may ask you this. Okay, this is again one of the important question which will be there for your either table viva or the oral viva for theory. What are the different biochemical tests which we use to differentiate between the atypical mycobacter and typical mycobacter? Like for example, niacin is very positive by Mycobacterium tuberculosis, negative by the atypical mycobacteria. Then the neutral red test, aryl sulfate test is positive by atypical mycobacter, negative by the tuberculosis. Then nitrate, amidase, all these tests are important for, and you must know when we are talking about the biochemical reactions of the mycobacterium. Of course, we don't ask you much about the resistance, but again, if the theory viva goes, if somebody has worked on the tuberculosis, they may ask you how many days they are viable in the sputum or in the droplet. This is very buzzword nowadays, droplet nuclei, because of the COVID-19 also, right? They remain suspended into the. Are you there, everyone?
Yes, 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 yes.
Okay. Okay. So droplet nuclei, this is a buzzword for today's, in the pandemic era, droplet nuclei. So even in the Mycobacterium tuberculosis, these droplet nuclei are very important. They remain suspended for 4 to 6 hours in the air, okay? And if a person is around these people who have coughed out, sneezed out, not sneezed, actually coughed out for the tuberculosis, they may spread the Mycobacterium tuberculosis, and if person is around that positive person may inhale these droplet nuclei and may suffer from the tuberculosis. So you must know in culture, look at it, 6 to 8 months they remain viable in the cultures. And why they die? Because we know the growth curve, right? It starts the lag phase, then log phase, then stationary phase, and then the decline phase. Why the decline phase? Because the nutrients are depleting, okay? They are going down. So that is why here they start dying actually. And after 8 months, there will be no nutrients available on the LJ medium. So that is why they die. They are very resistant to disinfect. This is something which is very dangerous characteristics of this organism. That's why if they get contaminated in the disinfectant, that will be difficult for all of us. Then they are very sensitive to formaldehyde. This is one of the important fumigation method which we use for operation theatre, formaldehyde and glutaraldehyde. Glutaraldehyde is used for plastics which are heat labiles. They can be killed in the, of course, if you are attempting the LAQ on the Mycobacterium tuberculosis, then this is how I asked you to write in a picture, in the flow diagram. Okay, so it is easy for us to read it out. What is the mechanism of entry of the Mycobacterium tuberculosis into the host? You can see here the droplet nuclei are going through the respiratory tract and reaching to the lungs. These are the lungs, and they are establishing themselves over there and forming the Gons foci. You know now Gons foci, those are the what you can say residing place for the Mycobacterium tuberculosis. Practically most of us have these Gons foci. We don't suffer from the disease because our macrophages in the lungs, they are very capable of taking care of these mycobacteria. They kill them, and so we do not suffer if your immunity is perfect, okay? So, but if your immunity is not perfect, a person is positive for HIV, they might go for a tuberculosis, full-blown tuberculosis. So what happens in the pathogenesis? Pathogenesis again is the ability of the organism to cause the disease. It is the mechanism, how it enters into the host. What it does, it enters through inhalation, they reach lungs. Generally what happens, it should happen normally in all of us who are immunocompetent, that they should be ingested by the alveolar macrophages. But what happens, they are so notorious, they multiply in the macrophages, and macrophages are not able to take care of the Mycobacterium tuberculosis bacilli. So they form the Gons foci, which I was referring about. You can see here, these are the the patches. You can see here, these are the patches of Mycobacterium tuberculosis infection, and this is the radio diagnostic method. You can, you can find out through the X-rays. Okay. Then what happens next? They generally involve the lymph nodes, and then they form a primary complex, and then healing and calcification occur. Generally, it is in the normal patient. What happens through hematogenous spread? They spread into the blood, and that is why it is called as miliary tuberculosis. This is the diagram of miliary tuberculosis. And most of the time they remain quiet for a long time and cause the latent infection. They do not do any halchal in the lungs. They remain quiet and they cause latent infection. And what happens once the person has this Bonn's foci or latent infection and they suffer from immunocompromised infections such as HIV, the reactivation takes place and then they turn out to be a tuberculosis. That is the secondary tuberculosis, and it is usually called as pulmonary tuberculosis. You can see here. You can see here the entire consolidation cavitation occurs. Okay. What is the tubercle? This we may not ask you in the practical examination, but we may you have to know about this when you are attempting the long answer questions. What are the different virulence factors of the Mycobacterium tuberculosis bacilli? Cell wall itself is one of the antigen, lipid, polysaccharide, phosphatides. These are all their weapons actually. And generally tubercle region is exudative form or the productive form, and the infection depends upon these factors: dose, virulence, mode, age. Age, why? In the extreme ages, of course, it is more common as compared to the adult one. Then you should also know about the various systems which are involved in tuberculosis other than lung. Of course, we know that the tuberculosis is the disease of the lungs, but it can also involve the renal, tubercular meningitis, that is meninges, then bone marrow. It can also cause infection to the joints. Miliary means it is in the blood. Intestinal tuberculosis, skin tuberculosis. So you name the organ, this organism causes infection, Mycobacterium tuberculosis. And in the tuberculosis, generally it starts with a fever, cough with expectoration, balgam jalamuntapan, and then hemoptysis means presence of blood into the sputum sample, which could be a warning signal that you are suffering from or patient is suffering from the tuberculosis. Patients suffer extreme weight loss, and because of the loss of appetite. In the TB patient, people suffer this weight loss and because of the loss of appetite. And then they started showing the pleural effusion, consolidation, cavitation in the lungs. This is the skin tuberculosis. You can see how clinical picture is there for the skin tuberculosis. Okay. This is the disease burden into the entire world. You can see here, India, we are the hub for tuberculosis. Almost incidence is of 2.1 million cases, which is quite high. Prevalence is almost 2.6 million. 40% of Indian population are infected with tuberculosis. Very bad, right? So it's a too dangerous situation in our country. Even we are suffering from right now with the COVID also. You can see here data from last 10 years or so, whatever years are there. In the US, look at the US data. They are very much in control with the tuberculosis. Okay, they have able to decrease the cases. Look at us. We are proud of tuberculosis. This is the disease burden in the pie chart. India, red zone. See here, 21% of global population are, infected with the. If you consider the global population, 20% people are infected in India. Other countries, 20%, and then small countries there also. Even if you look at Pakistan, is very low from us. Even they are doing better in the tuberculosis. This is something which is not good for us. We are even behind with the Bangladesh and all that. So we have to work on this also. And believe me, I think I have told you that you might come across with the gingival tuberculosis also. I think I have shared during my class with the Mycobacterium tuberculosis. I don't know whether it is there or not, that slide. But you will encounter certain patients in your OPD, in clinical settings, in your dental settings for gingival tuberculosis. And that time you have to be very careful. This was the latest news from the Sakar क्षय रुग्णाची अशी वाढली संख्या मल्टी ड्रग रेजिस्टंटचे रुग्ण बघा 2015 मध्ये 81 होते 16 मध्ये 80 होते मग ते वाढत वाढत 2019 सप्टेंबरला 700 म्हणजे जवळजवळ आता ते कदाचित 20 आहे तर ते 1000 पण झाले असते. One multi-drug resistant patient traveling in a Mumbai in a local train where thousands of people are there, and if he or she coughs out, she is going to spread lots of organisms in the vicinity, and people may get infected. Okay, this is something which is very dangerous. If a patient is active tuberculosis, she should only receive emergency dental care in the hospital. Otherwise should not visit the dental office, because active tuberculosis may lead to tuberculosis to the dentist also and to the supporting staff. So you should not treat for dental problems of a tuberculosis patient unless he or she has got. This is what I was talking about. Thought for the dental professional. I have showed you this slide. I know that now. I am not going to repeat it. Okay. This is the gingival tuberculosis. It might get differential diagnosis with the gingivitis caused by mechanical injury or with the chronic periodontitis on that has to be taken care of. Okay, this we have discussed. I'm not going. Okay, this is something which is important. The Ziel-Nelson staining technique has a capacity to find out how many exactly number of bacteria are there, and that grading system is called as revised National Tuberculosis Control Program. If you have exact number 1 to 9 in 100 field, you can write those number. Okay, per 100 field. If you have 10 to 99 bacilli per 100 field, then you can write it as a 1 plus. If they are 1 to 10 per ileal immersion objective, then it is 2 plus. And more than 10 AB bacilli per ileal immersion objective, then it is the 3 plus. What is the important? I have told you RNTCP. There are two important what you can say purpose of this. It will tell you the severity actually, severity of the disease. I think if you remember, we have discussed this also. What is importance of the RNTCP grading? It tells you the severity. This is more severe. This is less severe, right? So severity and then prognosis. What do you mean by prognosis? Prognosis of the condition of the patient. What is the condition of patient? Either good or bad. Good prognosis or bad prognosis. So we have to remember, if it is good prognosis means from 3 plus it is coming down to scanty, and bad prognosis from 1 plus it is going to the 3 plus. This is the bad prognosis. Again in the prognosis, it is good or it is the bad prognosis. Okay. So this is what you have to remember. Okay. This is again different methods which we use for the cultivation or detection of mycobacteria. PCR can be also used for diagnosis of tuberculosis. Nowadays we prefer PCR, which is rapidly gives you within couple of hours the person, and it can also tell you if the person is resistant for rifampicin. We detect that gene in the gene expert machine, and you can able to tell that yes, the person is positive for positive for tuberculosis and resistant for rifampicin. You should also know the Montauk test. That can also come as a short answer question, and it is generally done onto the 4-hour. This is also the example of delayed type of hypersensitivity. Okay, we generally give intradermally in the 4-hour, and then we measure the size of induration and erythema. If it is more than 10 millimeter, it is positive. That means patient had tuberculosis or had tuberculosis in the past history. And if it is less than that, it might be in the phase of the disease, or you can see here, if it might less than 5, it is completely negative. So Montauk's test, you should know. You should know the name of the drug for treatment of these tuberculosis. There are two generally broad antibiotic classes which we use, first line and the second line. You can see here the list of the drugs in the first line: isoniazid, rifampin, rifapentine, rifabutine, ethambutol, and parazolamide. And then generally aminoglycosides, fluoroquinolones are generally used for the second drug of choice. Okay, I am done with the lecture.